That was a wonderful demonstration of the trial. So I just have just a few minutes to go talk about the implant. So in general, what I do for my implants is I always create an incision at first. I don't have the leads just going percutaneously through and then incise because there's a risk of damaging the lead itself. So we're just going to use the leads that are in place, and I'm going to talk through how I do everything. So let's just assume that I do have an incision adjacent to our leads and that we anchor. Anchoring is the most important part of the entire procedure. So with anchoring, we are literally anchoring the system to the patient. And that is really the most important thing so that the leads don't migrate. Oops, sorry. Can I get a new knife? 5-second rule, thank you. And we want to make sure that the leads don't anchor. And what we used to do, and some people still do this, is incise directly onto the IPG. The issue with that is you can actually create some tugging or pulling. So I don't personally do that. So I try to make sure my IPG pocket is quite good. So what we're going to talk about today is a new entrant into the spinal cord stimulator market, and that is with Biotronic. They are a German company, and as you probably know, most of the spinal cord stimulator companies are American. So it's nice to have, again, some competition. Really, the hardware is no different than what you've already heard from Dan with Medtronic and Boston Scientific. The leads are relatively similar. The IPG, the idea of screwing in the leads into the IPG is relatively similar. So what I'm going to do is just talk about a little bit about how we tunnel, how we implant, and then some of the features of the system that really differentiate it in the marketplace and why you might consider it for your own personal use. So for all of the companies, you really want to know what the IPG template looks like. So you can see it here. This gives you an idea of what the IPG will look like in the patient. So one of the most important things, I've mentioned this in many other talks, is always have that conversation before you're actually in the OR. Where do you want the IPG? See what it feels like to sleep on your side, see what it feels like to drive or wear a belt or whatever else, and then have the patient come in that morning and say, this is where I want it because I've done the work. The last thing you want is to put it in a place where it's uncomfortable, it causes pocket pain or whatever else. That incidence is actually anywhere, depending on the study you read, 3% to 15%, which is a real issue because you can have patients who are doing great with the therapy but hate the way their pocket feels. So really important to do all that work. So in general, you can go in the buttocks or flank or even abdomen in certain situations. Like if you have a wheelchair-bound patient who has severe pain, spinal cord injury, you may choose to go into the abdomen because obviously you don't want to create a decubitus ulcer on their back, flank, or buttock. So, for example, if we chose to be up more lateral here, the drapes are sort of limiting me here, but I'll just arbitrarily go out this way and see here if we can remove some of the drapage. Do we have any Mets or heavy scissors? And this is a needle driver. Okay, so we'll work with what we've got. No, it's all good. So if we have this template right here, it's about 4 centimeters across. Again, we'd have this all marked out, but I just wanted to demonstrate tunneling just so you have an idea of how to do that safely. A lot of people look at the tunneling instrument and go, wow, that's really, dangerous, it's sharp or whatever else. Perfect. Not the sharpest blade that we have, but that's okay. So what you'll do is dissect that IPG site. I'll use finger dissection here. You can use METS, electrocautery. This is a rechargeable system, so I'll actually make sure that it's about 2 centimeters in depth. You don't want to be too deep because otherwise recharging could be not really capable. So we're at about a 1 centimeter, 1.5 centimeter depth here. You can see I just slipped the template in. That's when I know, great, my IPG is going to fit just perfectly. For the tunneling tool, what we do is we put a little curvature here, and you have a couple tip options. Either you have a really sharp, let's see which camera, a really sharp tip or a rounded, more blunt tip. Whatever one you choose is totally fine. So what I do is I actually finger dissect in the direction towards the IPG, and then I feel that plane of the adipose. And then what you can do is you can see where the tunneling tool is going. So you can see if I rotate this way, I'm going more cephalad. If I go this way, I'm going more caudal. And then I need to make sure my depth is at the level of the IPG, not too superficial where the lead comes down. So you really need to think in 3 dimensions. So without poking yourself, I can see, if you guys can notice, the tip is coming through, and then I can come right through that pocket site. Then what we do is just, usually have a scrub tech assisting you here, but you'll wipe your gloves, unscrew this, and then use DeBakey's, which we'll see if we have, which we don't. That's okay. I'll use these needle drivers. Perfect. And we'll grab the straw here and then bring that over. Do we have any DeBakey's, guys? Because I can't get a good grip. Mitch, DeBakey's? Okay, great. Perfect. Can't really do a surgical implant without surgical instruments, but that's okay. Anyway, so idea here is once we have the actual instruments, pull out the metal insert, then you have the straw, we'll tunnel the leads over, and then we connect it to our IPG. So one of the unique things about the Biotronic system, this is the Prospera IPG, a lot of companies just focus on getting through the trial, having a good trial, and then doing the implant. And then afterwards, it's really dependent on our representatives to make sure the patient's doing well. And for a lot of us who are neuromodulators, we think no news is good news, right? Patient, we don't see them for a year, and we assume, hey, if I'm not hearing from them, they're doing great. Truth is, that's not always the case, okay? And we know from the data from Pope and Van Byten that a number of these stimulators do get explanted, and the number one reason really being a loss of efficacy, a loss of therapeutic benefit. There are other reasons too, of course. Lower on the list is infection, lower on the list is you need an MRI, but the loss of therapy is really important. And so in pharmacologics, in pharmaceuticals, when we give a drug to somebody and we figure out how well does it lower their blood pressure, how much does it reduce their arrhythmia or whatever else, you can measure that. And if it's not working, the question is how compliant was that patient with their medication? Were they taking it 3 times a day? Were they avoiding dairy? Were they drinking grapefruit juice or whatever else? All the pharmacodynamic and pharmacokinetic issues that are involved in medications. With spinal cord stimulation, we just assume they're getting stimulation. We talk about different waveforms. We talk about this and that, cycling, et cetera. But do we know if a patient is compliant with their electroceutical? Okay, so I'm terming this electroceutical compliance. And one of the things that Biotronic is able to do is monitor the patient's use and which programs they're using. So we're going to show you here on the iPad one of the therapeutic monitoring reports, which allows us to see this is a particular patient, and then the x-axis is each day of use. And so the colored bars here are telling us what % of the time they're using a certain program. And the orange bar is program 6, for example. The yellow bars are program A. So we're able to identify which programs the patient is using, and then similarly, if they even turn it off. Okay? So what we may not know as neuromodulators is that there are a percentage of patients who actually turn off their stimulator, it runs out, they don't recharge it, or they turn it off for a surgery or an MRI and they forget to turn it back on. Well, with this data, this is being uploaded into the cloud every day at midnight, and we're able to identify these patients. And so a person from the internal team can let the provider know or call up the patient directly and say, hey, we've noticed that your stimulator's been off. Is that on purpose? If so, what are the reasons? And maybe it's just a gentle reminder to use it, turn it back on. And then that data can, of course, be uploaded to us. We can identify that as a provider and know what to do with that information. So this is what's really cool. The focus here is not just on the implant. Great, we all make our money and we leave and we let the patient go live their life. Now the focus is on what happens in the post-implant period. How can we ensure that the stimulation is working the way we want it to? How can we optimize the therapy so the patient's actually getting the greatest benefit out of it? Because as we know, there's so many different iterations of waveform, cycling, energy use, recharge burden, all these issues. It's complicated. And if we don't know how our patients are doing, we can't adapt and change. So the future really is this. And while all of the companies are sort of saying we have ways of doing remote therapeutic monitoring and all of that, this company has a history of that in cardiac rhythm management device. This is what they've been doing for years, and they've proven with a great track record they can do that in the cardiology space, and now they're bringing over to that interventional spine pain neuromodulation space. So that's one of the really awesome, unique features, and I'm really excited. I was the first to do an IPG implant April 24th in the world commercially, and so I'm looking forward to seeing how some of my first patients are doing. Some of the other features with this system include updated MRI conditionality to 3.0 Tesla without any major changes to SAR or energy transmissions of the MRs. So this is going to be really exciting. The first patient I did actually was a patient who had Parkinson's and is considering deep brain stimulation, which will require the use of 3.0 Tesla. So it's really exciting that we're able to use this system, allow him to get that particular therapy, and we'll see how things go. So with that, I will turn it back over to Doug, if there are any questions from the audience.
I do have one question for you, Ramo. So on the patient monitoring component of this, that's a fairly novel thing that we've just been introduced to. How do you expect that this will change or be additive to your practice?
Great question, Doug. So number one, this idea, the concept of remote therapeutic monitoring is really important. As you've already heard, it's used in other areas of medicine, cardiology being a primary user, but there are many others as well, neurosurgery, et cetera. And what's really important is there is a code for this, which you can bill for, but you've got to use it the right way. We cannot abuse this code. So every month, we need to track our data, look at the summary report, understand what's going on, talk to the patient, whether that's in person or audiovisual right now during the times we can, and then document exactly what we're saying, how we're going to alter the therapy, if at all, and then you can submit for reimbursement for that particular code. We need to all be very careful about how we do that. Again, if we abuse that, there's no question CMS is going to jump on that and say, hey, let's retract coverage or reduce reimbursement. So it's a very important code to use. It's something to build into your practice because, again, there's a precedent already in cardiology with doing that. Let's just be mindful and purposeful in how we use it so that we really can apply it the way we want to, which is to make the therapy better for our patient. And that's really the bottom line.
So great commentary on the fact that this is there's a CPT code for this. And to be careful with that code, similar to our colleagues in cardiology for remote monitoring. With that, I'd like to open it up for questions, comments. So, Ram, I just have one more for you. So, the system that you just demonstrated has the capability of remote monitoring. The rotating cathode aspect of this, would you care to comment on what that might mean for durability of the therapy?
Great question, Doug. So one of the things I did not describe was the use of multi-phase, which is a novel paradigm in stimulation. I don't want to call it a different waveform. It's the way the stimulation is actually applied to the spinal cord. So no matter what kind of waveform you use with any of the other companies, you're generally using an anode cathode array and then providing that particular mode of stimulation, and then you can add in cycling. So how often it's on versus how often it's off. Okay, so that's no matter what you use, HF10, burst, that's really been the paradigm. What multi-phase does is it changes the anode cathode array sequentially down the spinal column. Okay, so what that does is different segments of the spinal cord are receiving electricity at a different time sequentially, and then that's cycling over. And what that does is, number one, it reduces the amount of energy that is used. Key, right? So that allows for a longer period of time that the energy can run before it needs to be recharged. So that's number one. Number two, what it does is rather than applying the same electrical current to the same segment of the spinal cord where habituation, changes in the glial cells, the cytokines, et cetera, interleukins, et cetera, will manifest, adaptation is natural in the human body. So by changing where the electrical stimulation is along the spinal cord, you're not allowing that adaptation to occur. And so that's what I think is really novel with this particular paradigm in multi-phase. Great question.
Great. Thanks, Ramo. So any other questions or comments? Okay, with that, let's take a 15-minute break and encourage everyone to visit the exhibits that are just right across the hall. Thank you, guys.